Well, thanks, Tim, and thanks to Beth, who's also with us today. You know, these webinars go so smoothly, and one of the reasons is because there's a whole group of people behind the technology of all of this. So that's a wonderful thing that we have these. Welcome to everyone who's joined us today and to those who will be listening later. It's always a pleasure to be here today, and we're going to talk about one of my favorite subjects, which is everything about bowels. So before we begin, let me describe myself. I am a lightly pigmented female with a very ruddy complexion. So no, I haven't been out in the sun, and no, it's not high blood pressure problems or anything like that. It's just my natural way that I am. I have a black shirt on with white background. I do wear glasses for close-up work like the computer. I have new glasses that help protect against the light on the computer that's supposed to be helpful for your eyes. So we'll see how that works out. I also have brown hair, which is, if you would see me in real life, has lovely strands of silver. But fortunately for me, on the camera, it just looks all brown. So thank you, technology, for that. That's the cheapest hair dye job I've ever had. So anyway, I was thinking a lot before we get into bowels. I was thinking a lot about the news last night because the temperatures have been so high across the country, just, ridiculously high. And last night there was some flooding in the Midwest, or the night before there was some flooding in the Midwest. And I was listening to this devastation, and I frequently talk about safety and planning and what if there's an emergency in your home, and we always think of fire, maybe a gas leak or something that's going on, but we don't often think about if you live in an area where there isn't flooding, and then all of a sudden there's like close to 9 inches of rain that falls down in a short amount of time. I mean, this just happened in a matter of hours. And so there was this extreme flooding in the Midwest. Now there's been flooding in, in the South and in all different areas. This was nothing new, but it got me to thinking about safety when I was listening to these people, because even though people might have a safety plan for what they're doing or how, what they should be accomplishing and how they're going to keep their family members safe and how they're going to keep themselves safe, not often do we think about what if all of a sudden there's a flood where it's never flooded before. And I thought, oh my goodness, that's something new we have to think about. So I hope you all have a family safety plan in your home. If you don't, be sure and think about what kind of things you need to do to get out of your home safely, if you need to get out of your home, or if there's some danger outside, how you can be safe inside your home. And so think about what you're going to do, write out your plan, have the family discuss it, have everybody put their input in, and then actually do the plan. Because when you have a safety plan, you can talk about it all day long. But when you actually enact the safety plan, even though there's nothing happening, you just have a practice drill, you're going to find little kinks and little things. Oh, I didn't think about that, or oh, I wasn't sure about that. And so there's going to be all kinds of things. And then for something like a flood, what are you going to do? Well, in some areas, apparently the fire department came around in boats to get people out of their houses because their houses were flooding. And they said, come on, you have to go. And they're like, no, we're going to go up to the attic. Well, the flood kept coming and they were trapped up in their attics. So you see, when help comes, take the help and get out. It can also be a challenge if you have somebody who has some mobility issues. What are you going to do if you are relying on electrical functions? So if you have a power chair and the power goes out, your chair cannot recharge, what are you going to do for mobility? Or if a flood comes, you can't run your power chair through the flood water that's 6 feet high. You can't walk through that, and it's coming so fast. You shouldn't go out in that at all anyway. And so just think about all these different kind of things. But another thing that really impressed me when I was listening to the people is that some people had a plan, some people didn't, but they went with the rescuers. And so they all got to a safe place in a community center. And so they were feeling good, but you know, they were devastated because what's happened to their home. They didn't know all of their belongings. The water was just so high and it was just so fast. And then interestingly enough, several people said, I don't know what I'm going to do next. In the context of once we go from the community center, where am I going to go? Where am I going to live? What's going to happen to me after this? And I thought, a plan for after the emergency plan. So when you do your safety plan and you think about, okay, I'm going to go to the community center or however I'm going to remain safe. But what if there's a fire and your house has been destroyed? Or what if there was an explosion? Not too long ago, in a neighborhood not far from me, there was an explosion in this house and it really demolished like 5 houses all around it. It was really quite tragic. So the question would be, what are you going to do if everything's all destroyed? Do you have a family member you could go live with? Is there a place where you could go to take a family member with special needs, you know, where they can get in and out and move about and be able to do their daily activities? So I thought, I never really thought about the after effects of that. So that's something I'm going to add to my family safety plan is where would I go? How would I get there? You know, I don't have my purse with me. I don't have my credit card. So how am I going to go anywhere to get where I need to go? What's going to happen? Because when you leave urgently, you might not have time to go get your purse, or you might not be thinking about your purse. You're just thinking about, you know, saving everyone in your home. So kind of another part to that story. So if you already have that, good for you. If not, start thinking about adding that to your safety plan. Now, in this very, very hot weather, if your power goes off, some people are very sensitive to changes in temperature. Sometimes neurological diseases affect changes in temperature, and overheating becomes a thing. In the wintertime, becoming too cold, if your heat goes out, becoming too cold can be a real issue. So think about what kind of alternative power supplies you have, or if you don't have an alternative power supply and the air conditioning is off and the heat is off, can you go to a community center? Is there an emergency shelter where you can go, where you can remain safe for your own individual needs? Now, not too long ago, I was having some problems with my air conditioner, and I bought one of those little bitty tiny room air conditioners that run on water or ice. They only cost about $30 or $40. And I thought, well, I'm gonna try that just to have that on hand. And it worked beautifully about 5 times, and then it didn't work anymore. And I was kind of disappointed about that. So I could have done something wrong, or there could have been something defective with the device. But if I would turn on that device and just have it in a bedroom, like with the door closed, I could remain relatively cool just with that little bitty device. So that was kind of nice. Space heaters are very dangerous. You have to be very, very cautious with those. And if you don't have power, you're not going to have the electricity to run it anyway. So think about where you could go or what you could do if your heat or your air conditioning goes out and you really need those for your medical condition. Always be sure that you notify the emergency services, the power company, if you have somebody who's relying on equipment for life support. So if like somebody's ventilatory dependent and that is plugged into the wall for electricity, they do have a battery in them that will help them run for a short amount of time. But if the power is going to be off for 8, 9, 10 hours, or maybe even a shorter period of time, your battery might not last that long. So you want to let utility services know, you want to let the EMT people know so that when they come to your house, they are prepared to provide the services that are needed. So just be sure and do that. I've done that for a family member in my house who had problems speaking. And so it was always difficult to talk to 911 if they had to make that call themselves. And, you know, the 911 people like, sir, have you been drinking? You know, it's like, no, this is the way I speak. And so be sure and talk to the 911 people so that your house is flagged. This person has a speech problem, or this person has a hearing problem, or this person uses a ventilator, whatever kind of services that, somebody maybe even with a heart condition or something that needs a particular kind of care. So be sure and let those people know, because they're there to help you and they want to help you. And if you can give them a heads up with particular equipment to just bring on into the house and just get started, or if you get a call from this house, have somebody go check to see what's going on. All those kinds of things are very helpful in saving time, and they help everybody. They help you, they help the people trying to help you. And so it just works out really well. So think about all those things. That's a lot of things to think about that you might, I hadn't really considered that. Some people would get generators for their houses. Those are quite expensive, so that might be difficult to obtain. But you might find an organization in your community that's willing to get the money for a generator. They have to be serviced periodically to make sure they're still working and in tune. So, that's a big financial commitment, but it might be the thing that might make you more comfortable. So today we're going to talk about bowels. There's always questions about bowels. I think bowels is the #1 question. If I'm working in the clinic, if I'm working with patients, if I'm working with people in the community, it's always a question about bowels. Now, individuals who have issues with their bowel and bladder, they get pretty attuned to being able to talk about it without having much difficulty. But when you're new to it, it can be really kind of a challenge to talk about your bowel and bladder issues, because, that's private information. And so, you want to be able to be very upfront with that kind of thing, though. You need to just, say this is what it is, because your healthcare professional has probably heard it before, and probably you're not the first one. So, we have lots of ideas and lots of suggestions. So there's people who have problems with their bowel program. Now, this will shock a lot of people, but there are a lot of people who have no problem with their bowel program at all. They start their bowel program, it just goes like clockwork, and it stays that way for a long, long time. Now, sometimes people will have problems later on in life because our bodies change physiologically as we age. Things slow down in the bowel just as you get older. Bowel can get a little bit sluggish. It doesn't mean it's going to. It doesn't mean you're going to have problems as you get older. But I see somebody has already written in, and they're just like, they're having lots of issues. It's going on 6 years. Okay, so let's talk about bowels. Let's start at the very beginning. I'm going to talk about a whole lot of things. You may dismiss something I say, well, that's not me. That's not a problem. Okay, that's fine. You might say, that's not me. That's not a problem. Oh, but maybe it is. So really think critically about what you're doing with your bowel program. Now, something that people overlook is the very, very first step of digestion. And that is getting food into your mouth. So if you have trouble feeding yourself, is there equipment that you can get? Maybe a universal cuff that will hold a fork for your hand so you can feed yourself. Or maybe you might need one of these attachments that's like on pulleys, so that your arm, if you have a little bit of movement, you can use your arm. Or maybe somebody is feeding you. Maybe you're using a tube feeding. If you have swallowing difficulties, perhaps you've had a stroke and you have oral motor issues, and so maybe you're using a tube feeding. So think about what is the most safe way to get food into your body. Now, let's talk about food. Your diet is a linchpin to how your bowel program is going to work. So you want to eat a healthy diet. You want to include a lot of roughage. So you want to eat a lot of vegetables. Uncooked vegetables have even more roughage in them. Lots of salads, lots of things that will add bulk naturally to your diet, because bulk is what's going to move that stool through your bowel later on. Also look at your mouth. Are your teeth present? Sometimes people have been in an accident, sometimes through different for whatever reasons, they've lost some of their teeth. And so they have a very difficult time chewing. Chewing is that first part of digestion that's going to break down the food. Your saliva gets into your food, it breaks it down some more. So a lot of digestion occurs in your mouth. And so that's kind of an interesting prospect, where it's like, didn't think about that. So if you have mouth sores, if you bite the inside of your mouth a lot, there are all different kinds of things that can be done to help you swallow that food and get that food down and get it chewed up properly. Looking at your food is very important. If something looks appealing to you, that's going to make you want to eat it more. A lot of times after spinal cord injury or after some head injury, people who've had stroke or head injury have neurogenic bowel in 30 to 60% of that population. So that's a lot of people who are having bowel problems who don't equate head injury with bowel issues, but that's a huge problem. And if chewing is a problem, that's going to be the first issue to look at. But looking at your diet as well, looking at that food. So it should be food that's appealing to you. During the COVID, we were all trying new recipes, and I like chicken and I like pistachios. And I came across this recipe to coat your chicken in crushed up pistachios. And I thought, wow, two things I like. So that sounds really good. So I'm going to try that. I cooked it. It didn't look too appealing, but I knew it was going to be good because it's chicken and pistachios. How can you go wrong? And then I took a bite of it. Well, that was not the flavor combination for me. So that all went in the trash, I'm embarrassed to say, but it was so awful. And so if you have some food that you just really cannot stand, kind of shy away from that food. That doesn't mean that you can just go ahead with all carbohydrates and sweets, because those things are going to affect your bowels in different ways. So it usually tends to give you more diarrhea. But think about the food that you're eating. Add fiber to your diet. Beans are a wonderful staple to add fiber to your diet. And there's all kinds of lists of foods. You can even Google foods high in fiber and pick off your list what you think would be good. Avoid processed foods. Think about how that food smells when you're going to approach it. Think about Thanksgiving, and you smell that turkey cooking in the oven, and the aroma gets stronger and stronger. And by the time that turkey's served, you're like, wow, I want some of that Thanksgiving turkey. So it's that kind of thing. Think about that, the way the food smells when you're preparing it and how much you're going to enjoy that food. These are all things that help the bowel program, and they're important things. It's not like, well, yeah, maybe that a little bit. No, those are very important things. So think about all that, the texture of the food when you're eating it, if you're able to chew it, if you need softer foods, consider all those kind of things. If you have tube feedings, you might want to think about what kind of tube. You're not going to get the flavor of the food because it's not going to go in through your mouth and smelling it. It's going to go in through your stomach, but that can lead to a lot of diarrhea if it moves through the system too fast. Some people have a hard time adjusting to those tube feedings. Some people have a tube feeding through their nose that goes down into their stomach, but long-term there'll be a little valve that's put into your stomach there that the tube feeding can hook up to right up to the area of your stomach. And so some people will have those running really slowly while you're getting used to it, those real slow feedings that just drips in a little bit constantly of food. That's very helpful. That helps with diarrhea. You can get formulas that are the nutritional formula that you need for your body with added fiber. So you can get that added to your feeding as well. And then as things progress and your body gets adjusted to that tube feeding entering into your stomach or maybe even into your upper bowel, as you get adjusted to that and the diarrhea slows down and dissipates, then you can move into slowly working up to bolus feeding. So you have a feeding at breakfast, a feeding at lunch, and a feeding at dinner. Now, some people will just opt for feeding all night long. That's another option too. So, you know, there's a lot of combinations to talk about if you have a tube feeding. Once you get the food in your mouth, you've swallowed it, it needs to go down your throat. Sometimes people will have strictures if they've had if they've been intubated for a long period of time, or they can have all kinds of swallowing difficulty, maybe from a stroke, or maybe from some other kind of head injury, or, you know, just from life living. Sometimes people get a stricture in their esophagus or in their throat. So if you're having trouble swallowing, always talk to somebody, because they can help with either therapies to help you swallow, or sometimes they can put a tube in there and just stretch out that stricture. And so then you're fine. People who have had open heart surgery, and they don't do a lot of that anymore because they can do it through the cardiac cath, they can replace valves, they can open blood vessels. So they don't do a lot of the opening of the chest. They still do some, but it's not as prominent as it was just a few years ago. But people who have had open heart surgery, sometimes years later get an esophageal stricture as a result of that surgery. So that's just something, you know, I just toss out there, just another little added reason why you can have trouble. Okay, now you've got the food in your stomach. And so sometimes you might feel like your stomach is full, or you're just not hungry. Sometimes the bowel is so full that it's the substance, the waste is moving through slowly, and you're digesting very slowly, and you just don't feel like eating. There are some things you can help stimulate the bowel to move faster. There are medications that you can take to make you feel hungry. There are all kinds of treatments. So if you're feeling full all the time, you really need to look at your bowel program to make sure you're emptying out on the other end, that it's not just stacking up in there, because, you know, you're not going to want any more food if you're full, if your stomach is full of stool, or your bowel is full of stool. So sometimes it's just hard to get that notion that you want to eat. So maybe eat in smaller amounts throughout the day. Instead of your 3 big meals, have 5 much smaller meals. So once the food gets into your stomach, the digestive enzymes are going to start working on that food, and it's going to become more like a liquidy kind of thing. And it's going to pass through into the small intestines. And so that's where most of the nutrients are going to be taken out of this liquid, which when it goes from your stomach into your small intestine, it really becomes, it's more of a thick liquid. It's called chyme, chyme. So if you think of chyme, it rhymes with slime, and that's really what's good. It's kind of this greenish, because bile has been added to it. So it's this kind, you know, to help further break it down. So it becomes chyme, and that's what's passing through your small intestines. Now, the whole time it's passing through this chyme is passing through your small intestine. And even when the chyme starts to go into the large intestine, where it starts to form into stool, water and nutrients is constantly being taken out of that stool. That's what your bowel is doing. It's taking out nutrients, it's taking out fluid. So you have to be well hydrated. You have to think about your hydration. Make sure you have enough fluid in your body that stool can stay moist until it passes out of your body. And that can be a challenge if you're on a bladder program that limits your fluid intake. So if you are having problems with dry stool, also called constipation, which is different from neurogenic bowel, if you're having problems with that, you will want to talk to your healthcare practitioner. We used to add fiber to people's diets, Metamucil, Citracil, those kind of products. They're called laxatives, but they're fiber laxatives. So they're not laxatives that work unpredictably, but they add fiber to help push this chyme through the bowel. And what has been released recently is that in the new guidelines is that people who are on bladder management programs don't take in the fluid needed to push the fiber laxative through your bowel. So what happens, and I see this a lot when I go into different institutions, or I'll see people, if you read the instructions on the bottle, you need with the powder, or even with, if you eat the fiber cookie or whatever form you choose to have it in, there's a great deal of water that you have to drink to make that pass through your bowel effectively. What I see is people who are on bladder management programs, they might put it in a cup of fluid. I've even seen people in the hospital setting hand a person their fiber in one of those little 30 cc medicine cups with a little bit of water on top, and they kind of stir it in there very carefully. Here's your fiber. That is not enough fiber, that water, to help that fiber. That just turns that fiber into cement. And so what they're recommending now is, if you're on any kind of fluid management program for your bladder, maybe you have a heart condition, there's a lot of different reasons why people can't just drink fluids ad lib as they wish. And so if you can't take in that amount of fluid, but you're taking that fiber laxative, you're creating a cement ball inside your bowel, making it even harder. And so people are like, I'm taking my fiber, I just don't understand it. Well, if you look at how you're taking that fiber, that was probably the reason. So they're saying, you can get enough roughage through your diet. So, be sure and if you're taking that fiber laxative and you're unable to take the fluid, don't stop it, but talk to your healthcare professional, because your body's been used to that fiber laxative. And so you might need to cut it down in slower amounts. Or they might say, I've seen people on bladder management programs where they take their little measuring cup of how much they have, and they put a little bit in their fluid that they're going to drink all, throughout the day. So they keep adding to it. That can get a little tedious if you don't like the flavoring. If it's non-flavored, then I guess it doesn't really matter. But these are all kinds of things that you need to think about. So if you are on a bladder management program or have a fluid restriction and you can't get that fluid in, you're probably making your bowel slower, where you've been told you're making your bowel faster, but you're not. So that is one of the huge, huge issues. Then as that chime goes from the small intestine to the large intestine, that's when a lot of fluid is going to be drawn out of the bowel. And so it's going to get real dry in there. So the longer that the chime or the forming stool stays in your body, the more fluid that's going to be drawn out of there. So a lot of times people will say, well, I don't eat much and I don't have a very big bowel movement. So can I go to a 3-day-a-week program? And sometimes, very rarely, sometimes people will say that's okay, but it's really not a good thing, because then you've got 3 days of that stool in your bowel, water coming out, water coming out, water coming out, which is going to make a very hard, constipated stool to get out. So sometimes people think, they don't really understand neurogenic bowel, because, it's not a word that we hear a lot out in the world. There's no commercials on TV, but neurogenic bowel requires a bowel program. Constipation is a different problem, where the stool is too dry. Anybody can have constipation. That includes people with neurogenic bowel. But people with neurogenic bowel don't necessarily have constipation. You can have neurogenic bowel and not be constipated. So treating constipation is not the treatment for neurogenic bowel. You still may need treatment for constipation, but that's not the treatment for neurogenic bowel. So if you're going to the store and you're getting all these products for constipation, they're not going to help you with your bowel elimination with the neurogenic bowel. They might soften the stool. There are things you can take. There's stool softener medication you can buy over the counter. I don't know why, but it must be a popular item, because you have to ask the pharmacist for it. You don't need a prescription, but you have to ask the pharmacist for it. Now, if you have a prescription, your insurance may cover it, so you may have a prescription for it. But if you need a stool softener, you have to ask the pharmacist for it. You can't go over to the shelf. You used to be able to, but it must be an item that was stolen frequently or something, because you have to ask the pharmacist and they have to get it off the shelf behind them in their locked area. I just find that to be somehow hysterical that so many people are trying to get stool softeners, but okay, that's one thing. again, if you can increase that roughage in your diet, if you there's a different foods that will help move your bowel a little bit more quickly, and those foods you will learn on your own. There's there's lists of foods that help with diarrhea, and there's foods that help with constipation. So there's always these lists, and I kind of laugh at them because some people will have food to help constipation and will have bananas. Yet I know other people that won't eat bananas because it gives them diarrhea. So you kind of have to learn for yourself. Bowel programs are a lot of trial and error because they're so individual. We don't know how much your bowel has been affected by your head injury or your spinal cord injury versus not having one versus other problems. So there's a lot of things that go into it. Some people have a greatly affected bowel. Some people don't have such a greatly affected bowel. You know, so it's just kind of figuring out what's what in your own self. There are people who eat beans as a dietary staple. They eat beans every day. So if they're having constipation, they want to add roughage, they can add more beans, but they're already eating beans maybe two times a day anyway, through their regular dietary habits. So it's kind of difficult to say, you know, add more beans. Well, I'm already eating. Well, okay, we're going to have to look for something else to add that roughage because, you know, how many beans can you eat? It's kind of like, oh, well, all right, you're already doing that. So then we do something else. So those are all important things. Now, when we get to the removal of the stool, there's two ways that we go here. There's the reflexive bowel and there's the flaccid bowel. Now, people who have spinal cord injury, who have an injury in their thoracic or cervical, so up in their neck and up in the bones in the upper chest, the thoracic area are the vertebrae that have ribs attached to them. So that's where those areas are. And those people generally have a reflexive bowel. It has a lot of tone. It's spastic. And so what happens is that it will clamp down. When you're trying to do your bowel program, you need something to stimulate the bowel to work, to lower that, to empty out that, evacuate that lower bowel. And you also need to stimulate that bowel to work. So there's two sphincters. There's the external sphincter that you see, that's your rectum. And that's under control of your brain. So if you don't have a brain damage to your brain or spinal cord that affects that area, and you have a higher level injury. So for people with brain injury, if they're upper motor neurons, that's the area that is really the controller of the neurogenic bowel. And so a rectal exam is done to see if there's functioning in the sphincters too, sphincters in the rectum. And you can tell if you have an upper motor neuron injury or a lower motor injury based on that test. So if you have the upper motor neuron with the cervical and thoracic area, or on that upper motor neuron strip area, affecting the brain, affecting that part of the spinal cord, you're going to have this reflexive bowel. The external sphincter is probably either going to be spastic or but it can be easily relaxed. The internal sphincter is the one that gives everybody the problems. So the first thing you want to do with this upper motor or this reflexive bowel is you want to put some kind of stimulant or something in there that's going to create the bowel to work. And people usually start off with a suppository. They're cheap, they're effective, and that's why they use those. Okay, here's another big mistake that people make. I have yet to meet anybody who I've said, okay, this is the bowel program and this is how you're going to do it. And they'd be like, now what now? What are you saying? I don't think so. But this has become your new normal. And so you can get used to it. I know as a nursing student, I was the same way. You want me to do what to somebody? And I thought, oh, I don't know if I can do that. And then I decided if I put on a glove, I can do anything. And so suctioning, mucus, bowel, stool, urine, anything. If I've got my gloves on, I'm good to go. Vomit, good to go. But if I'm in my home and I don't have my gloves on, oh, and my child vomits, I'm like, I don't know about that. But anyway, that's the way that I've worked it out in my mind. And so maybe that will work it out in your mind as well. But anyway, you always want to wear a glove because when you're dealing with the bowel, there's bacteria in the bowel that helps digest the food. You could have a little cut on your finger somewhere. And when you put that into the rectum, if you don't have a glove on, that bacteria could get into that cut and get infected. So, okay, we don't want that. So we always want to be fully gloved, and you always want to put a generous amount of lubricant. Sometimes people I see them put a little dot of lubricant because they don't want to waste, and just put it on, and when it goes in, it'll spread down. Well, that little dot of lubricant is not going to spread over all areas of your finger. So be generous with your lubricant. It's goopy. I know it's messy, but, spread a little around on there. When you're at home, it usually comes in like a toothpaste looking like tube. So put a little glob on there that's sufficient that is going to really moisten that lube finger, because a dry glove is going to hit against the tissue in the bowel and it's going to be rough on the bowel. Anything in your body is not expected to be touched. It's not durable. So you want to have a lot of lubricant on there to avoid hemorrhoids, to be able to do your suppository insertion or to do dig stimulation with the least resistant up against the bowel wall. Because if your glove is dry, it's against a wet bowel wall, it's going to be glom onto that bowel wall, and you can make little tears or whatnot in your bowel wall. So be careful with that. Use plenty of lubricant. Okay, so you need to put your whatever you're going to use in your bowel. Some people use the Ducalox suppository. That has a vegetable coating. It takes a few minutes longer. It might take 5 minutes or 7 minutes longer for that coating to melt off before the stimulant begins to work. Some people like that little extra time. Some people like the Magic Bullet, which does not have the vegetable coating. So as soon as you put it in, it starts to work. Some people like to use the mini enemas, and those work really quickly. Here again, you need to use lubricant when you inject that. Regardless of what you use, don't ever use a full enema, because that flushes out the bowel and doesn't mimic its natural action. A bowel program will mimic the bowel's natural action. So it's preserving that function of the bowel, that it's a redundant kind of action that the bowel does to move stool along in it. So that's why we always go with the bowel program as the first line of defense. If you put in that suppository or you put in that mini enema and it does not go up against the bowel wall, it will not melt. So if you have stool in your lower rectum, you put the suppository or the mini enema in, and it goes in the middle of that stool, it's just going to lay there and do nothing. Okay, so a lot of people they just push that suppository up there, they wait for it to work, nothing's happening. I don't understand why nothing's happening. So if you check your bowel with that glove finger, you might find that there's stool in there. You may have to manually remove it before you put in whatever's going to be working in your bowel, the suppository or the mini enema. They work in different ways. So, it depends on what you prefer and how it works for you. So that's another area to think about, is if you're not putting it, if you have stool in there, but you can feel with your finger and be able to push that suppository around that stool into the bowel wall, well, at least it's going to hit along the bowel wall, and then it has a ripple effect. It's going to work much faster if the lower level stool is already removed. Then you wait about 10 minutes for that item to trigger. And then you might want to go in and you might want to transfer to the toilet at that time. So you're not sitting on the toilet for hours and hours, because when you're sitting on that toilet or commode seat, there's nothing supporting your rectal area. So your body weight is being pushed down through that hole in there. So you have to do your push-ups. However you do your pressure releases. You might want to do side to side, make sure there's cushioning on the toilet seat or commode. So transfer over to the toilet seat. If you're not having any results, you want to do the digital stim. You're going for that internal sphincter with these higher level injuries. You're going for the internal sphincter, and that is the one that you're trying to relax. So when you insert your finger, feel for that internal sphincter and very gently. Again, people want to get in and get out, and I'll see them doing their bowel program. When you have a reflexive bowel and you're doing this, you're making that internal sphincter tighter, and you're making your bowel program last longer. It's making it more difficult. It's prolonging everything. So you're doing the digital stim. You're trying to relax that. Some people just think, oh, I just need to open up whatever. They don't know that they're trying to relax that internal sphincter. You may not feel it. You may get close because it's really high up there. You may get close enough. You might, if you're very gently doing the digital stim, which will take a little bit longer than that quick, speedy approach. It will take, but you will relax the internal sphincter, because remember, you're trying to relax that spastic sphincter. So if you can get that to relax, then the stool will come out much faster. So that is helpful. And you can repeat that in another 10 minutes if it's not working. Again, be very gentle, and you can repeat it again the second time. If you still don't have results, then you might want to wait until the next day and repeat again until you get those bowel results. So that's for the upper bowel, for the upper motor neuron bowel. The lower motor neuron in the spinal cord injury is in the lumbar or sacral areas. It's in the lower part of the motor strip if you have a head injury. For this, the bowel program is a little bit simpler in that you're going to use manual removal. So you want to take that gloved finger, you insert it into the rectum, and the sphincters are going to be, they're flaccid. So there's not going to be any tone to the sphincters in there. So you don't have to worry about relaxing the internal sphincter because there's no tone. This is why people who have these lower level injuries or injuries to their lower motor neurons, they sometimes have incontinencies where the stool just drops out, and you're like, oh, that's not the time I want to do that. You want to have your bowel program at a predictable time so that you don't have embarrassment when you're out in society or whatever. You don't have skin breakdown, because if you don't have sensation and you're sitting on a stool, or urine for that matter, that's going to erode your skin, and that's going to make skin breakdown more prominent for you. So you go in, you take your finger in a little hook-like motion, and you can bring the stool out and empty the lower bowel doing that process. Now, if you don't have finger function, you can buy devices to insert suppositories. You can buy devices for digital stimulation. You have to have a little bit of arm function, but you can use a universal cuff and put one of these stimulator devices, attach it to your universal cuff. So if you have arm function, sometimes people are able to do that. There are different ways that you can toilet. You don't have to go with your back onto the toilet tank. If you're on a commode chair and it has arms, you'll probably want to do that if you want to have your back against the back. But if you have some sitting balance, sometimes it's easier to face the tank of the toilet and go head on that way. You can use the toilet tank to rest on. And sometimes it's easier to toilet in the backwards position because you don't have to worry about getting around to the back of the toilet seat. You can do it from the front. And for some people, it's easier. Again, these are things that you don't want to try on your own, because if you topple off, you could have, quite a head injury, or you could really get hurt. So have somebody with you if you want to try that, or try working in your rehab facility and say, I would like to try this differently, or see, because there's all kinds of little variations that can help you. Now, doing your bowel program, no matter which way you do it, it's best to do it sitting upright. If you have some sensation or tone in your legs, if you can elevate your legs, so that your feet are up on a little stool, that is helpful. If you don't have muscle tone, it's probably not going to do that much for you. But something that will help your bowel program is if you're doing exercises, passive or active. Passive means that you're moving your legs or someone else is moving your legs. Active means your legs are being moved, like either on an FES bike or you're able to use your legs to a certain extent. And if you're doing that, that's going to stimulate the muscles in your legs, which helps protect you against the secondary complication of diabetes, because those big muscles moving repetitively, that's very helpful. It is also very helpful. The muscles in your legs interact with the muscles in your abdomen. So that's another helpful thing to get those bowels going. Using a standing frame, that helps gets the bowels going. Even though your legs aren't moving, you have the gravity where you're standing up, and that's helping pull the stool through your bowel. It works. It just does help. So there are all different kinds of things movement wise to your legs that will help your bowel program. So you have diet and you have exercise and looking at your fiber laxative is a thing. If you have some problem and you can't sit on a toilet or a commode. Now, I know in a lot of rehab centers, they teach you to do your bowel program in bed because they don't have time in your rehabilitation stay to teach you to do it sitting upright, because those stays have become so short, just shorter and shorter and shorter. And so some people, I've met people who have 2 weeks, and that's not enough time to get a bowel program regulated. Some people are regulated in 2 weeks. Some people are regulated much sooner than 2 weeks. Those people are the lucky few. Most people, it takes about 6 weeks to regulate a bowel program. You can do it in the bed, but it's going to be slower because you're not able to take care of gravity, to use gravity to your benefit. Gravity is key in a bowel program. So sitting up is just paramount to a bowel program. If you do have to do it in bed, say your spinal surgery is not yet stable, or for some reason you can't sit up for some particular reason, you do have to lay in the bed, then anatomically you want to lay on your left side because that's the way the bowel curves around. So that's a little bit easier for the bowel program if you're on your left side, but gravity is the key. So that's another big thing with the bowel program. So there are lots of these little nuances with the bowel program that people, are like, I don't know. Some people have incomplete injuries and they have sensation in their bowel, or they feel pressure in their bowel. And so you can get analgesics that you can administer into the rectum. The mini enemas, you can get a formulation that has an analgesic mixed in with it, so that if you have sensation, that really helps cut some of the problems with that. We've been talking a lot in some of the other webinars with people who are on the cutting edge of these neurostimulators. We talked with the Onward company, who has a really neat electrode array that is put in minimally invasive into the spinal column. And then there's an external device that supplies the electrical input to the spinal column to increase your function and to be able to do different things. Just this month, we talked to Dr. Reggie Edgerton and his team, and they have done internal implants, and they're still working on those. They have been quite successful with those as well, but they've also are having a lot of success with an external implant. And so there was a gentleman there, a fantastic individual, who is on that videotape. So be sure and listen to it, because he describes that when he uses this external electrical stimulation device on his lower spine, that he has started to discover that he had gotten sensations for what it felt like when his bladder was full, what it felt like for when he needed to toilet. And he's been able to modify his programs based on his needs rather than on timing, as we do. And I know that I hear a lot from people, living under this bowel program, and it has to be done at the same time. it has to be done at the same time. You're training your bowel to work. Some people will do it in the morning today. Oh, I don't have time till evening tomorrow. The next day I'm doing something different, so I don't have time for it at all today. No, you have to set a time, and you have to be just as rigid as stone with it. There are ways that you can change your bowel program to a different time, but you cannot do it willy-nilly. You should not think about changing your bowel program unless something like really huge changes in your life. Like, I can't get it done before I go to work in the morning, so I need to change into the evening, but you can't change it back and forth every couple of weeks, because like I say, it can take 6 weeks to up to 6 months to get your bowel program adjusted. And even after you have it adjusted, like some of our readers have, listeners have written in, and they're like, my bowel program worked fine, and then all of a sudden it didn't. Yes, because all kinds of things affect your bowel program. Even your mood can affect your bowel program. There was a wonderful writer, and I wish I had saved this because I think about it so often. He did a tongue-in-cheek article about his bowel program, and it was all about this trip that he took in his station wagon. He was all dressed up because he had to drive, I don't know, maybe an hour away. I don't remember quite all the details, with his fiance to meet his fiance's parents for the first time. Had a well-organized bowel program. He's going to meet his fiance's parents. He's a little anxious about doing that, pretty normal reaction. And what happened? He has diarrhea in the car. He had a change of clothes, but not dress up clothes, because he's all dressed up for this big meeting. And he talks about how he had to change in the back of his station wagon, and he's with his fiance, and he's thinking, oh, what's she thinking? And what have I signed up for here? And because his bowel program was well regulated, and then disaster just struck. And that seems to be the way it is. Something's going on and disaster strikes the bowel program. And it's usually because, oh, I'm at a job interview, I'm meeting my fiance's parents for the first time. It can be, I got bad news. It can be, I got good news. And, all of a sudden your bowel's just like doing its own thing. And you're like, wait a minute, now we had a deal, bowel. We were working on this and it was just fine. So there are lots and lots of things. So there's a lot of details in the blogs this month. If you want to go back and review, there are all kinds of little tips. So really critically think about your bowel program and the things that you are doing. And maybe you're doing everything exactly right. So you need to talk to your healthcare professional about trying something different. Maybe you want to try one of these mini enemas. People seem to really like them once they get them. You'll have to check to see if it's covered by your payer source. Some people will also elect to do, I talked about some alternatives. There's a thing called Peristeen, and it's a different company that does something else. It's a lower bowel irrigation, like an enema, but just for the lower bowel. There's a lot of tricks to using it. Some people like it, some people don't. But that's like everything. Some people like their suppositories, some people don't. I mean, this is not like, I'm not like saying, oh, people don't like that, because there are people that do like this. But there are little things, tricks and time savers to get accustomed to using it. So there is a little bit of a learning curve, just as there is with any bowel program, but they do have people that you can call and they can help. So it's like it looks like a little laboratory beaker, and you fill it with water. You want the water to be warm, because if it's cold, it's going to spasm that bowel. So you want it to be tepid, not hot. You don't want to burn your bowel. You fill that, and then there's a knob that you have to turn. So you have to have a little bit of hand function. The one in Europe runs with, like an electrical pad, where you just tap the buttons. So it's a little bit more functional in that way. And then there's a short tube that's placed into the bowel, and water goes in there, and then when the water comes out, it empties the lower bowel. So some people like that. Some people have gone that route. Some people elect to go to the colostomy route. Now, as a healthcare professional, we like to put those off, because if you have so much problem with your bowel program, your bowel's no longer working for some odd reason, then we revert to the colostomy. We try to keep people using their natural bowel function as long as they can. So, but if you elect to have that colostomy, talk it over with your doctor, your healthcare professional. Surgery is required. Surgery is always risky, even more so people who have neurological disease. And sometimes people say, oh, I just don't want anybody doing that for me, so I'll get the colostomy. People sometimes have extreme complications with colostomy. If you look at the picture of people wearing a colostomy in the ads, they all have 6-packs. I don't know very many people that have a 6-pack, whether they have neurological injury or not. So sometimes it's harder to keep the bag on. Sometimes there's a bowel explosion and the bag comes off. Sometimes there's issues with gas collecting the bag. So it's not the panacea that some people think. However, there are people who have elective colostomy and it's like the most freeing thing they've ever done. So I'm not trying to negate any of this. I'm just giving you the whys and the wherefores. These are all your decisions to be made with the healthcare, with your healthcare provider. So there's one more question that was brought up today, and it is probably because of the last blog that I wrote, and I had a little section in there about the complication of hemorrhoids in there. And the recommendation is always to have those, is if you have hemorrhoids and you need to have them removed, to do so by occlusion. That, you know, that if you've heard people talk about the rubber band technique, they kind of put a tight band around the hemorrhoids and then they fall off because they're not getting their blood supply. That happens in a slower fashion, and so the hemorrhoids seal off better than if you have the surgical removal, because they're cut off with a knife, and then getting the hemorrhoids to close off is a bit more difficult. They're cauterized, they might be stitched, but still bleeding is a bit more of a challenge. So is the occlusive method more often used than the surgical method, the cutting method? And it's for 2 reasons. It's because of the amount of bleeding that can come in the surgical procedure. And the other is breathing. Yes, my friends, breathing. So you think, well, what do hemorrhoids have to do with breathing? Well, when you're in the surgical position for hemorrhoid removal, your legs are up in stirrups and your rectum is exposed. You might be on a breathing machine. So it's difficult sometimes for people, even with lower level injuries, to get off the respirator. And then also because of the positioning, if it makes it harder for people to breathe during that type of procedure. If you have like a local type of procedure, it's just more difficult to breathe in that position. So those are the 2 reasons why. So that is why usually the occlusive method is the method of choice. And you can read about that in the PVA guidelines as well. So there's more information on that. So with that, we have reached the top of the hour, and I very much appreciate you coming today. I could do another 4 or 5 hours on bowels. So anyway, I hope that this was of some help to you. Go back and look at the blog, and you can really walk through the different steps and look for different problems or issues, and you can comment on the blog as well and say, you know what, this really worked for me. Because if you have something that's working for you, you might be the lifesaver for somebody else who is just had it with their bowel program. So if you find something, we all want to hear about it. We all want to know about it. So thank you very much for coming today, and I'll see you next month.